We have usually have a contingent that comes in a few minutes late, so.
Take a seat, Brian.
Well,
Okay, sure.
We're going to go ahead and get started this morning. This is our next installment of our visiting professor series for this academic year. This is the Donald P. Chan visiting professorship in spine surgery. So this is named in honor of Don Chan. I know many of our residents and fellows don't know Dr. Chan, but those of us on faculty, he mentored many of us. He was an icon in the field of spine surgery. He was our chief of spine for many, many years. Dr. Shen and I were his residents and had the opportunity to learn from him. He contributed so much to our department in so many ways, not only in building the spine program, but expanding the care and problems that we took care of for spine patients here for over a decade. He retired probably 10 years ago, but we've named this visiting professorship in his honor, and he often comes back. He'll be coming back, from what I hear, to our alumni meeting in April, so it'll be great to see him. But he is really, him and Dr. Whitehill built this spine division and were the foundation for what we have now and the incredible spine program that we have. So this is a great honor to recognize Dr. Chan for all his contributions to this, to the University of Virginia and to all the spine societies that he was leaders in. So he taught us a lot about his mission experience in spine surgery as well over the years. So really remarkable man who many of us who trained into are very fortunate to have crossed paths with him. So I'm going to have Dr. Shen introduce our visiting professor who got in at 1 o'clock this morning, and we were unable to have dinner last night, but glad he's here, and it's really an honor for him to. We're just honored to have you here, Dr. Kwon.
Thanks, Dr. Chaba. Dr. Chen was a past president of SRS, so it's really a great honor to have this fellowship talk in his name and to have Dr. Kwon here. Dr. Kwon has been a long time sort of colleague and friend to several of the division members here in spine. I think you did your fellowship at the Rothman Institute, where Adam Scheimer, our own Adam Scheimer, was a fellow, I think slightly after you, right? A few years after you. He's been a colleague and a collaborator with our own Dr. Lee, who's our vice chair of research. We did several conferences and meetings together when we were younger, but we haven't done as much, and we need to do more as we move forward. When you think about Dr. Kwon, I've really been following your career for years, not so much because I'm interested, but if you're a spine surgeon, a neuro ortho spine surgeon, or any sort of traumatologist, you have no choice but to follow his career because he's been really impactful in what he does, and we'll hear a lot about that today. He's an internationally known surgeon scientist. He did his medical degree at Queen's University, he did his orthopedic residency at the University of British Columbia, subsequently got his PhD there as well in neurosciences. So he's an MD, PhD, and he did his fellowship at the Rothman Institute. He's also the director of the Spine Fellowship there. When I did a deep dive on his CV, I know Dr. Kwon well, but when I did a deep dive, his CV is probably, for lack of a better word, daunting. He's a tenured professor at the University of British Columbia. He's a spine surgeon at the Vancouver Spine Program at Vancouver General. He holds chairs in the Canadian Research Chair in Spinal Cord Injury. He's the Dvorak Chair in Spinal Trauma. He's the Associate Director of the I-Cord program and the Research Clinical Research Program there, and the Director of the Vancouver Spine Research Group. He's the Director of the Spine Fellowship, as I mentioned. He's really a talented surgeon and a dedicated researcher. His clinical care is, as you could imagine, in degen and in deformity, but really his interests and passions are in spinal cord injury. He does and runs one of the largest clinical trials in North America in spinal cord injury. His research is translational. He has created and established the International Spinal Cord Injury Biobank, which, because of his interest, looks at sort of the human pathophysiology and the biomarkers of spinal cord injury, and has created sort of novel models to look at therapeutic strategies to try to better understand and hopefully make therapeutic treatment for patients with devastating injuries. He's a principal investigator and associate director of the I-Cord Institute, which is an international collaboration of investigators, including spine surgeons, but also urologists and radiologists and rehab medicine and neurosurgeons, really looking at trying to develop and advance the care of spinal cord injury patients. When you look at that website, there's, I think, over 40 investigators, principal investigators, looking at all aspects, not just the direct injury of spinal cord, but the sequelae associated with it. He's funded, as you would expect, multi-million, multiple funds, not just through the Canadian National Research Foundation, but through the Department of Defense and through private and societal fundings. He's got the requisite 300 plus papers and book chapters and books. But I think if you think about his impact, you can see it spreads beyond orthopedic spine and neurospine, because he is the recipient of the Delta Kappa Award, which, as everybody knows, is the largest research and the most important research award you can receive in orthopedics. He was a North American Traveling Fellow in 2003, which is not just orthopedists, but it's really not just spine, but orthopedists for North America and you're the Canadian representative. And he was an ABC Fellow in 2011. And he was recognized really as one of the top 40 under 40 as a leader in spinal cord research. So it's really a pleasure and an honor to have Dr. Kwon here. Dr. Kwon.
Thank you. Yeah. All right. Well, that was a very fine introduction. Thank you. And good morning. Oh, can you hear me? Okay. All right. Fantastic. Wow, what a great group. I was just reflecting in Vancouver, we're just starting to resurrect some of our in-person 7 a.m. Ours are at 7 a.m. as well on Wednesdays, but they've since the pandemic, they've all been hybrid. And so actually they've just been largely online. So it's great to actually see people and there's just nothing like getting your entire group together for rounds. So a big thank you to the spine group here, and it's a real pleasure to be here. And sorry that it's such a short trip. I got in about 1, and then I'm heading to Chicago with some of the other spine guys for this meeting in Chicago. I'm going to talk about spinal cord injuries, as it's been one of that's been really the main interest of my academic career. A bit different for an orthopedic surgeon, but back in the day, the spinal cord injuries were cared for by the orthopedic group in Vancouver. They created the spinal cord injury unit. And so doing my training there, it became kind of natural for us to go into spinal cord injury work. Although many times I think most people actually think I'm a neurosurgeon just because of my background in neurosurgery or in neuroscience. I have some disclosures that aren't really relevant to what I'm going to talk about today. So I'm from Vancouver. Vancouver is a very pretty part of the West Coast, and Vancouver General Hospital is a level 1 trauma center and the referral center for all spinal cord injuries in BC. So we're a big province, and if you're injured in the northern parts of BC, it's a 2.5-hour fixed wing aircraft flight to get down to Vancouver. But we accept patients from all over the province. And then about 15 years ago, we built the Blessed Spinal Cord Center with the notion of trying to put all the clinicians and scientists and whatnot under the same roof to try to accelerate progress in spinal cord injury. We had smatterings of people all over the city and different campuses and whatnot. So this was the intent, to put us all into the same building. I'm part of a great group of ortho and spine surgeons. So we have actually been a combined spine ortho neuro group for like 20 years, over 20 years. So one of the first experiences and going into that foray of trying to collaborate with neurosurgeons, which I think we can all agree can be challenging, but we actually had a tremendous group. And so we don't do ortho neuro call, it's just one spine call schedule. We all have our offices amongst one another and share secretaries and whatnot. So it's a great group. And then alongside that, developed a research program within ICORD with a number of techs, students, clinical research people, and whatnot. So, so with that background, I'm going to really spend this talk really talking about the thing that I guess we argue about the most, really, in spinal cord injury, which is like what actually improves neurological outcome. Because at the end of the day, that really drives like a lot of the care for the acutely injured patient. And the things we kind of argue about include steroids, the timing of surgery, and then how to actually hemodynamically manage these patients. So it's funny, I've given a lot of talks on cord injury. It's hard to escape a talk without somebody asking me about steroids, which is something that I almost feel like we should have moved on from many years ago. But because it always comes up, I thought, well, I'll talk about steroids. And I won't belabor the point on steroids, but just a very brief perspective on steroids. Like, so, you know, considering the original steroid trials in their most favorable light, yeah, you know, they described a 5-point improvement in motor function. And this is why steroids to some extent became a standard of care for many years in North America and around the world. If you could if you get patients start within 8 hours. It's possible, although it was never proven, that there were certain subsets of acute spinal cord injury patients that might have benefited more than others. And this is one of the justifications that used to come out when people were saying, oh, steroids don't work. But yeah, but they may work in certain populations like incomplete cord injuries. That was never actually proven. And there are definitely complications that exist, and people described a lot of different papers describing the complications. But if it were actually real, a 5-point motor improvement would actually be meaningful to most patients. And if you actually ask patients if that would be meaningful to them, they would generally say yes. But for many years, it actually had become a treatment option. Like people had moved away from using it as a standard of care. And we in Vancouver, we probably haven't given it in like 25 years. So we're one of the groups that basically moved away from it. So it remains a bit controversial, but I think that for people that still like to use it, it's an option. And I think most people in North America have actually moved away from it. But we don't want to necessarily criticize people that continue to give it. It's just if that's what they feel that they want to do. So that's kind of the very brief scoop on steroids, and hopefully that won't become a topic again. As we're surgeons here, I think that we all like to talk about surgery, and then obviously for us, probably the biggest topic for surgery in this is like, when do you actually do it? How urgently should you actually do it? So there are actually two issues, I think, now with respect to surgery for spinal cord injuries. There's the issue of timing and how expeditiously you can get a patient to the operating room, decompress their spinal cord. But there's also, I think, a burgeoning interest in technique, like how you actually decompress the spinal cord. So we'll talk about timing. It's the topic that should these spinal cords be decompressed? And if that should be done urgently, like how urgently should that be done? And at the end of the day, what's the actual benefit? Like, what is the neurological benefit to having your spinal cord decompressed as early as possible after injury? The STASCA study that Michael Failings led was a prospective observational study from almost 2 decades ago. And it's a prospective observational study because nobody could agree to randomize patients to a late decompression in the study, quite naturally. So early surgery was kind of operationally defined at 24 hours. It ended up being kind of around the median time to decompression. And so it became kind of the operational definition of when an early decompression would actually occur. And this is the money shot from STASCA, which at that time was the largest trial to ever look at the effect of early surgical decompression. And what this shows is that the dark bars are patients with early surgery, and the gray bars are patients having late after 24 hours of surgery. And those that achieve 2 and 3 grades of ASIA grade improvement are shown there in that bottom right. And it indicates that the black bars are bigger than the gray bars, suggesting that, in fact, patients that had early surgery within 24 hours of injury had a higher likelihood of going up 2 to 3 grades on the ASIA scale. So ASIA A to C, or ASIA A to D, or B to D, or whatnot. Now, the peculiar thing about this is that the patients that achieved 1 grade never changed. So there wasn't actually an improvement in that, which is always a little bit of a peculiar finding in Staskus. But in any event, Staskus became kind of the first, here's like, data to show that there might be a justification for doing early surgery. The Staskus study was combined with a number of other data sets by Michael Failings. They basically pooled data from Staskus, the North American Clinical Trials Network, this host of institutions in North America. NASCUS 3 was the final steroid study. And then Cygen was a drug that was tested way back in like the 1990s. Was actually the largest prospective randomized study ever done in spinal cord injury, 760 patients, and it was negative. So nobody really talks about Cygen much, but the data set is out there. So they pooled these patients to get a data set of about 1,500 people, 1,000 of them treated 24 hours and after, and about 500 treated before 24 hours. And the results of this suggest that there was actually an improvement in motor score of about 4 points. And this was statistically significant. And if you did this forest plot, in essence, it looks like everything kind of favored surgery. That neurological improvement was higher in those that had surgery before 24 hours. Here again, similarly, if you look at conversion, the number of people that converted, particularly 1, 2, and 3 grades, was a bit higher in the red, which is the early surgery, as compared to the blue. And so that actually fit probably a little bit better than the Staskus, where there was all this kind of result in like the 2 or more, but there was actually no results in the 1 or more. And I was asked Michael this, like, if neuroprotection is actually trying to get these small gains out of the spinal cord, why is it that there wasn't any difference in the 1 or more? But if you look at a larger set of patients, you see this kind of pattern emerge. So early surgery, patients were more likely to achieve that improvement. Now, this is actually the results of motor function. So how much motor function improvement do the people with early surgery get? And this was actually probably the most surprising part of the study, was that if you look at cervical, because we all think, well, the patients with cervical injuries are the ones that are probably going to gain the most. The thoracic injuries, high energy injuries, fracture dislocations, they're probably not going to gain much. And there's no segmental motor function in the thoracic spine like you have in the cervical spine. The change was 2.2 motor points for the upper extremity score, 1.3 for the lower extremity score. And in the thoracics, it was actually 4.4. So surprisingly, the motor score improvement was actually higher in the patients with the thoracic injuries, which I think for us, is an important message around the management of some of those thoracic injuries, where we think, super high energy injury, they're not going to gain much. But in fact, they have potentially just as much to gain from early surgery as the cervical patients. As an aside, the steroids were looked at in this patient population, and there was no benefit to steroids in this meta-analysis. So again, I think they just said, well, we have all these patients with steroids, we should check, and there was no benefit. This became part of the guidelines initiative that we published back in the spring. So Michael Failings and I undertook this as part of through our roles at AO Spine and the Praxis Spinal Cord Institute, which is an institute back in Vancouver. And we, in March, published a series of papers with new clinical practice guidelines for surgery, for hemodynamic management, and for intraoperative spinal cord injury. So what do you do if you're in the OR and you lose your motors suddenly, like what is the management of that situation? So, so with respect to the timing of surgery, we recommended that early surgery at 24 hours be offered as an option for adult patients, kind of regardless of level, cervical or thoracic. And so this is actually a stronger recommendation for early surgery than what had been published in 2017 when we did the other guidelines. And we thought that particularly having that meta-analysis with 1,500 patients provided stronger evidence that early surgery was potentially better for these patients. Now, the topic comes up then is like, what about ultra early? Like what happens if you have somebody who's like in your emergency department and they've just come off the rugby field and they're like an hour after injury? What about the benefit of doing ultra early surgery, not necessarily within 24 hours? We actually did review this for the guidelines. And as it turns out, there were 4 papers that had been published on the results of ultra early surgery. So one of them was published by Bijan Arabi, and the definition of ultra early was actually less than 12 hours. Early was 12 to 24, and then late was after 24 hours. And what they found was basically that there was much difference in this patient group. So timing didn't seem like ultra early, late didn't seem to make a difference. There was this Austrian study where they did ultra early surgery in patients like, and I think a lot of us would say, yeah, if you can get a patient to the operating room within 5 hours of their injury, that's pretty early. So 5 hours, early was 5 to 24 hours. And as it turns out, early did better than the ultra early in this patient group. So the ones that had surgery like in that kind of fire drill of less than 5 hours did actually worse. But the ultra early patients were also the more severely injured patients, and so that confounds so it's harder to come to the conclusion that ultra early surgery patients necessarily were worse. They were worse to begin with. This study from Germany also looked at early being less than 4 hours and found really no big difference between early and late. And finally, this was actually the only paper that looked at, they used an 8-hour cutoff and found that there was actually some benefit in the patients that were treated ultra early. So that was kind of the summary. And so people asked us, well, why didn't you make a recommendation about ultra early surgery? And it was because of basically this. It was the definition of ultra early was a bit all over the map. And really the results weren't particularly consistent. So we made a recommendation that ultra early surgery is still a little bit of an unknown. So the recommendation is really around 24 hours. Now, question that I think is actually quite peculiar is like, well, why is that? Because when you think about it, you think, well, why would it be hard to demonstrate that somebody that has their spinal cord decompressed at 4 hours post-injury wouldn't have a better result than somebody that had their spinal cord decompressed at like 22 hours post-injury? I mean, you'd think that would be pretty easy. You'd think that'd be probably easy to establish that. And so people are now actually thinking about doing a trial where they push the timing even earlier. So why is it such a problem? I would say the fundamental challenge to all of these studies on surgical decompression, when we talk about, well, how long does it take between like the time of injury and the time that they get surgically decompressed? But the issue that clouds this interpretation is actually the timing at which you do the baseline exam. The timing at which you do the baseline exam. And that is very hard to factor into these issues because when you do that exam, influences a lot of how much spontaneous recovery actually people get. And I haven't met a single patient who, fell off their bike or they fell off a hill on the ski hill and they were lying in the snow and they described this period of complete paralysis. They all described that. I was completely paralyzed. And then, on the way to the hospital, I started to be able to wiggle my toes. And so even people with the most incomplete injuries will actually experience a period of complete paralysis at the time of their injury. So if you examine them at that time, they can look very different than what they're going to look like later on. Now, and we know this intuitively. So if you take a patient and there's 3 days post-injury, they can still, there's still some variability in what that patient might look like down the road. So, yeah, 72 hours after injury, you say, yeah, this patient's Asia A. Yeah, it's likely that they could be Asia A at the final analysis, but it could be that there's something else. Now, let's say you examine that patient 3 months after injury and they're Asia A. Okay, you're probably pretty confident, that patient's probably going to remain Asia A. But let's go back. And if we go back in time and do the exam at 20 hours after injury, well, then intuitively you know that the variability is going to be much greater. Right? And then what about 6 hours after injury? Again, the further you go back towards that time of injury and do that baseline exam, you know there's going to be more variability. And then what about right at the time of injury? What if you did the exam right there on the scene? What would happen? Well, so this is actually one of my patients, his wife filmed this. So he falls off the mechanical bulb. And this actually was in Vancouver. Like, I don't know where these mechanical bulbs are in Vancouver, but in any event, so that's what it looks like to suffer a cervical fracture dislocation. And so if you examine that person then, of course, he's looking like a complete Asia A spinal cord injury. And he came in with that bilateral facet dislocation. But 6 months after that injury, so I did an ACTF on him, he was normal. So he was playing tennis. So it goes to show you that, if you do that exam really early, people look actually remarkably the same. But there's just a lot less certainty about what they're going to be like based on that very early exam. So basically, you could be just about anything if you do that exam super early. And this issue fundamentally clouds the interpretation of early surgery studies, because you can control we did the surgery between 0 and 5 hours. But if you do surgery at 5 hours, you're examining that patient probably within 2 hours of them arriving through the doors, right? We actually looked at the effect of this in 85 people with cervical spinal cord injuries that were Asia A, and we looked at whether or not at how much they recovered based on when we did their exam. And basically, if you do your exam within 4 hours of injury, their conversion rate is almost double. So this is kind of intuitive, so doing an early exam. And this is unfortunately one of the things that's hard to factor into a trial of early surgical decompression or ultra early surgical decompression. And I know that people are actually now, I think Sanjay and UCLA has actually got a DoD grant to do an ultra early surgical decompression trial. And somehow they're going to have to manage this issue. So we didn't make any recommendation about early surgery in the guidelines. The other thing that's really, I think, emerging around surgery and this concept of timing is actually technical, which is actually kind of fun because it's we're surgeons and so we're into technical things. But so timing early is probably better. And certainly, when people ask me about all the nuances of timing, I say, well, look, if it was your daughter, how soon would you want her spinal cord to be decompressed? Right. But the thing that is actually emerging that is interesting, I think, is really around technique. So here's a patient that sparked a lot of interest in our program. She had the C5-6 fracture dislocation. You can see a little bit of bleeding within her cord, with the red arrow. And then you can see the edema that goes up and down her cord, really from kind of C2 down to T2. So she gets an ACDF, restoration of her alignment. For us in orthopedics, that's kind of how we manage a lot of bilateral facet dislocations, single level ACDF. Gets put into the unit. She has her blood pressure increased to 85 millimeters of mercury. And on day 5, she loses her biceps function. So that was what she came in. She lost her biceps function. And we got the MRI to see what was happening. And this is her MRI. So you can see she's been realigned. You can see the plate from the ACDF. But you can see that the hemorrhage in red kind of is now all through here. And you can see that the edema now goes all the way from her brainstem, goes all the way off the page. So when you look at a case like this, you ask, is the cord actually decompressed here, right? Is that actually decompressed? We've realigned the spine, we've opened the spinal canal, but is it truly decompressed? So there's a neurosurgeon in London who has done a lot of interesting work in this area, Maris Papadopoulos. And what Maris has been doing is, in a situation like this, he's doing a posterior laminectomy, and he's putting a pressure probe, a Codman pressure probe, through the dura and into this space between the thecal sac and the spinal cord, to measure the pressure as the spinal cord has swollen up against the thecal sac. And it's kind of like, it's funny when the neurosurgeons describe it, they're like, hey, we heard this is kind of like a compartment syndrome. But yeah, it's kind of like a compartment syndrome in a way. So you just imagine, and here's your spinal cord within the CSF, and you put an intrathecal pressure catheter there. Of course, that catheter is going to measure the pressure of the surrounding fluid, right? But then if the intrathecal pressure is really the CSF pressure. But then if the spinal cord swells and then actually expands and pushes that pressure probe against the thecal sac, well, then that catheter is actually going to potentially measure the pressure inside the spinal cord. And this is really what Maris has been doing. So this has been an ongoing area of research in London, and really speaks to the issue of like, how do you then create a decompressed spinal cord where that pressure phenomenon doesn't happen, where the cord pushes up against the thecal sac. So Bijan Arabi at the University of Maryland, which I think he's now retired, but you know, he did a lot of work at shock trauma. They were doing post-operative MRIs on all their spinal cord injury patients. And he coined this term that if you saw the post-operative MRI like ours and you did not see CSF fully around the spinal cord, you would say this is not decompressed. Whereas if you did see CSF fully around the injury site, this was a fully decompressed spinal cord. And he did some work to show that the ASIA conversion rates were definitely higher in people that post-operatively had this complete decompression in CSF around the spinal cord, whereas those that did not convert, in particular, had this phenomenon where the cord was not fully decompressed. So this goes beyond timing, right? This is more of a technical issue. The question then is, well, how do you actually get this to happen? Like, how do you technically get this kind of decompression? He did another study on 184 patients where they looked at pre and post-op, and they found that the longer of a laminectomy you did post-operatively, the greater the chances were of getting the spinal cord decompressed. Right? So anterior procedure alone, half the cases still had compression. Turn it over, do multiple levels of decompression at the back, and you have a greater chance of getting that decompressed. So around the time that came out in 2019, and I was like, wow, that is fascinating. So this is one of the first patients that I did back in 2019 that in which I thought, well, I'm going to do kind of what Bijan suggested. So she was a rollover motor vehicle accident. She has like multiple spine fractures. This Ditzel C2 I thought was actually stable, but I used it as an excuse to actually instrument that level. And I went big. I did something to totally decompress her spinal cord, give her all that kind of room to swell, give that spinal cord room to swell. The physiatrists, who are very good at doing the INSCI exam, they documented her as being ASIA A, C4 ASIA A. Even 3 weeks after the injury, they documented her as an ASIA A. So she had some biceps, flicker of wrist extension, and nothing else below that. I saw her back a year after her injury, November 2020. So she's fully healed. And at this stage, she's T1 ASIA B, which I was shocked at. So this is somebody who then now has normal function in her hands. So she went from having biceps and a flicker of wrist extension to having completely normal upper extremity function. And they even documented at physio that she had abdominal control too. So I have been admittedly much more aggressive with surgical decompression kind of since this came out. Because it is something where I think, well, if we have a chance to give people even a little bit more motor recovery, then that would be actually a good thing. So, so it's funny how our practices have changed. In my training, like bilateral facet dislocation like that, we would do an anterior cervical discectomy infusion and be pretty happy that that was going to heal. Now we're doing that plus a long posterior laminectomy to try to get this result where you see CSF fully around the cord. And I don't know if it went, you know, I just think if it was me, I'd probably want this spinal cord and not that spinal cord in the post-op period. Okay. So that's surgery. And the final thing I'm going to talk about is map augmentation. Because map augmentation is one of those things that we have some influence around. I'm not sure who manages that here, but I assume it's your intensivists and whatnot. But we've always been interested in map augmentation because there have been guidelines around what you should do with people's blood pressure after injury. Even back in 2007, it was recognized that we didn't have a lot of great data to guide this. Despite that, the neurosurgeons put out these guidelines in 2013, and they indicated that the mean arterial blood pressure should be maintained between 85 and 90 millimeters of mercury for 7 days. So that was recommended, and that was sort of the guideline that we adhered to locally as well. But what are they actually based upon? This is one of the great things about orthopedics. Like you go back and you look at like the actual literature that substantiated these sorts of guidelines and whatnot. That so what are these based on? Well, they're based on largely these two papers. That there was the Levi paper from '93 and the Vail paper from '97. The Levy paper was that shock trauma, 50 patients, kept the map over 90. There was no control group, and they didn't even like make a statement about map. They felt that aggressively monitoring the patients was what was really good. They put swans in them and stuff. So. And they thought that it was good, more based on their pulmonary vascular resistance, not on the map. But that is widely cited as one of the reasons to keep the blood pressure up. The Vail paper, again, looked at 77 patients. They maintained the map at 85. There was no control group. And they came to this conclusion that map augmentation was a good thing. But the cool thing is you read the paper and you actually go into the discussion. And this is taken verbatim from the discussion. This is the Vail paper. We do not know the ideal map necessary to maximize spinal cord perfusion. We're not aware of a way to measure spinal cord perfusion. And we arbitrarily selected 85 millimeters of mercury as the target map. So that was 1997. That's what has been propagated to the guidelines in the last 25 years. Okay. And I don't think that's like a totally unique phenomenon. I think a lot of things in orthopedics probably undergo something like that. So we did a systematic review on all the papers that looked at map augmentation and found that really, if you look at it, it's very low quality evidence. And the connection between a map target and neurological outcome, that relationship is actually still rather uncertain. So that was also one of the things that we in the guidelines group tried to tackle. And guidelines these days, it's quite an interesting endeavor. Like it's not like a bunch of people you get together and you talk about how good the quality of the evidence is. It's actually compiling the evidence in a systematic way, but then subjecting to this grade methodology where you bring in multidisciplinary teams. So our hemodynamic management team included surgeons, but ICU doctors, anesthetists, nurses, neurologists, emergency docs. It also includes people with lived experience. So people living with spinal cord injury participate in these, and they all participate in the voting around the recommendations. So we looked at 28 studies, and this is sort of the summary of all of it. It's not meant to be read, but if you just look at the far right, all of these things were largely very low quality. So if you really scrutinize the work, and if you put things against the grade framework of quality, like it's very humbling. So like my own studies are in here. It's like, it's heartbreaking when they come back and say, yeah, we graded yours as low quality. But yeah, so it's a very rigorous way to look at the literature. But we asked these questions about like, well, if we're going to have a map target, what should be the lower limit of it? What should be the upper limit? And how long should we treat for? And should we use certain drugs? Those are kind of the main questions. And the conclusion that we came from out of that was we suggest a MAP target of 75 to 80 at the low end, 90 to 95 millimeters of mercury at the upper end. We felt that there wasn't enough evidence to direct people towards a specific vasopressor agent. And even though I'm very interested in spinal cord perfusion pressure, there was no recommendation around spinal cord perfusion pressure. Now, we knew that this was going to happen. People were going to say, hey, what the hell's with the range? Like, why would you put a range at the range? So this 75 to 80 at the bottom end and 90 to 95. And we wrote a whole paragraph about this in the discussion. Essentially, what we're looking for is, here's the concept of having a little range at the top and a little range at the bottom. And it's actually, if you go to the ICU, it's not easy to just put somebody on vasopressors and keep them like at a specific level. They bounce around kind of a lot. And we thought, well, if we have these range, then you'd have the patient, their MAP would be kind of bouncing around. And then if you get into this situation, like, oh, they're in the lower part of that range. So that would actually then potentially trigger you to say, oh, maybe we need to actually move, like maybe increase their vasopressors and get them back up. And then similarly, oh, we're now in this upper range. Now maybe is a good time to start to back off on some of the vasopressors and try to keep them down in that range. And really the intent was to try to avoid going past or avoid dropping below. But we know that if you just say, 75 to 95, just keep them in that area, that, you can get up there, ooh, now all of a sudden you're above. And at the other end, oh, you're dropping, ooh, now you've actually fallen below. So that was kind of the rationale for actually putting in that range. So my intensivist, which is funny, I was in the OR, and they're like, hey, Brian, like, what are we supposed to be doing with MAP? I'm like, well, what are you talking about? They said, well, we've read your paper that came out like last week. I'm like, really? You seriously read the paper? Like, it came out 4 days ago. But yeah, our intensivists were actually all really keen to know what they thought we should be doing. So this is what we do now, is if you have a severe ASIA A or B injury, I think keeping them in this 80 to 90 millimeter range is fine. We think 7 days is probably good. If you're C or D, I think keeping them in the range, but you probably don't need to be in there for the full 7 days. And I think, in talking to people, it's hard in many institutions to keep a patient in their ICU for a full 7 days just to be on vasopressors. So we think that that's probably fine. We do think, and this wasn't necessarily the reason for putting an upper limit on it, but we do think that there's a good reason for the MAP having an upper limit, and it has to do with hemorrhage. So we know that the injured spinal cord bleeds, just like any other tissue would bleed after you traumatically injure it. And we often know, like, if we see a patient that comes into into emerge and we see that blip of hemorrhage in the spinal cord, we all kind of think, that's not a good thing. Like, that's a bad prognostic sign. And it's well known that like hemorrhage like that, bad prognostic sign. But there's more to the bleeding than just a bad prognostic sign, because the blood breaks down, and you all know that it breaks down and it creates all these breakdown products. And it turns out that those breakdown products are also harmful for neural tissue. So things that then exacerbate hemorrhage are probably not good for the spinal cord. They break down, the hemoglobin breaks down into iron. Iron can create free radicals. And so there's actually these mechanistic things that people have worked out about how the breakdown products of blood are actually bad for the neural tissue. So we, like many other people, have seen hemorrhage progress in the spinal cord after injury. If you do serial MRIs on them. And that you can kind of see, you can actually measure this on the T2 weighted imaging, like the hemorrhage actually expanding. And we thought, well, what are the things that could cause that to worsen? MAP exposure, right? Like you get a patient with bleeding in their cord and you drive their blood pressure up. That could potentially cause them to bleed. And the other thing that we do, which I think many people do, is in addition to that, what do we put them on 2 days after injury? We put them on prophylaxis for DVT, right? So we anticoagulate them. And it's funny, I talked to our ICU guys, and because I'm not a neurosurgeon, and I was like, well, what do you guys do for like the hemorrhagic strokes? Oh, we don't push their blood pressure. That'd be terrible. I'm like, really? And so what do you do? Well, we CT scan them, make sure their hemorrhage is stable before we drive their MAP. I'm like, oh, and what do you do with the anticoagulation? but we hold that until like their hemorrhage is more stable. That's not being the practice for us. Like we drive their blood pressure up, and the minute that, you know, maybe as soon as they're sort of 12 to 24 hours post-op, we hit them with enoxaparin. So we're very interested in actually this question of like, hey, is bleeding actually exacerbated by these common techniques? So we started a clinical trial where we decided to do 4 post-operative MRIs on people in the first 2 weeks of injury. So pre-op, day 2, day 4, day 7, and day 14. And then track their mean arterial pressure recordings and track when they got their DVT prophylaxis. And then quantify the hemorrhage on their spinal cord based on the T2 weighted image. So you take a patient, they get all their MAP recordings over the first week that they're in the study, and then you look at when did we do the MRIs. So here are the baseline MRIs. And so if you really want to know, well, what was the relationship between MAP and hemorrhage, then you kind of want to know well, if these are the intraparenchymal hemorrhages measured at those periods of time, you want to know, well, what was the MAP exposure between those two points in time? And what was the change in the hemorrhage over that same period of time? That's how you would do it. And that would be the delta intraparenchymal hemorrhage. Similarly, if you wanted to look at like day 1 and day 4, you would look at, well, what was the MAP exposure? What was the change in the hemorrhage over that period of time? So 13 acute cervical spinal cord injuries. They all had some degree of intraparenchymal hemorrhage at the beginning, worse in the patients with AJA. Now, if you looked at the relationship between MAP and, so here we have the MAP and we have all these changes in intraparenchymal hemorrhage. So if we plot that over on the y-axis and we plot this MAP exposure on the x-axis, let's say there was no relationship at all between MAP and the change in intraparenchymal hemorrhage, then you would see something like this. So yeah, 95 millimeters mercury, you get a 20 millimeter squared change in the intraparenchymal hemorrhage, but not really any different than if you just raise patient, or if you have them at 87. So that's kind of what, there's no relationship, and you would have a regression line that looked like that. So this is what it actually looks like. So on day 2, there's certainly some association between MAP and intraparenchymal hemorrhage. And at day 4, there's an association again between intraparenchymal hemorrhage and MAP. And probably the most important factor was the baseline intraparenchymal hemorrhage. So patients that came in with a lot of bleeding in their cord were the ones that were most prone to having more of that propagated if you drove their blood pressure. Between day 0 and day 4, the things that came out as being important was the MAP exposure, and also the baseline intraparenchymal hemorrhage. So it kind of suggests to us that if we see a patient that comes in with a lot of bleeding, those are the patients that are probably going to be at most risk to having that bleeding expand if those are the ones we push their blood pressure in. And to some extent, it sort of suggests to us that this might be one of the reasons why in these particular patients that it might be worth being maybe a little bit less aggressive with their MAP support. And really, like, maybe that's part of how we could tailor the hemodynamic management of some of these patients when they first come in. The other bigger picture thing about MAP augmentation is you sort of ask, is it really the right metric? So the TBI guys and the neurosurgeons and all of us that get our ORs bumped by the neurosurgeons putting in their EVDs understand that in traumatic brain injury, they're watching the cerebral perfusion pressure as the difference between MAP and intracranial pressure. And that relationship does exist in the spinal cord, where the spinal cord perfusion pressure is equal to the MAP minus the CSF pressure, which can be measured with an intrathecal catheter. So you can imagine that if the MAP is 70 and the CSF pressure is 15, then the spinal cord perfusion pressure is 55. That can be increased by increasing the MAP. It can also be decreased by reducing the CSF pressure. And you can do that by potentially draining CSF out of the lumbar catheter. We set out on a study a number of years ago to actually put intrathecal catheters into acute SCI patients and looked at these metrics and how they related to neurological outcome. And we found if you looked at every data point in this patient set and correlated it to like who got better and who did not get better, we found that for patients with spinal cord perfusion pressures that drop below 50, If you had more of those episodes, you had definitely a higher rate of non-conversion. So low spinal cord perfusion pressure was very bad for the spinal cord. And interestingly, this was not true for MAP. So it suggested to us that indeed the spinal cord perfusion pressure was probably more relevant to neurological recovery than MAP. Similarly, being exposed to low spinal cord perfusion pressure drops your likelihood of conversion by almost 50% if you're exposed to that in the first 24 hours. So we published that to say low spinal cord perfusion pressure is bad, probably more predictive than MAP for neurological recovery. But, and then we wrote a subsequent paper to suggest that 65 was probably a better spinal cord perfusion pressure, and patients that were at 65 had a higher likelihood of getting better. So if that's true, then obviously the question is, well, what's better? Actively trying to manage somebody's spinal cord perfusion pressure or giving them the same conventional MAP management, either with lumbar drains or with vasopressors. So we embarked on this study called CASPER recently, where we put lumbar drains in and we drained CSF to try to bring that intrathecal pressure down and raise the spinal cord perfusion pressure. A big study across a number of centers across North America. And we stopped the study recently at 58 patients. We had done this. So what have we learned? We're actually writing the manuscript currently, but what we've kind of learned is when you think about the two things that we surgeons and clinicians can do for these patients, it's surgery and their MAP management. It turns out that these concepts are kind of linked when it comes to spinal cord perfusion pressure management. And the reason is that monitoring the spinal cord perfusion pressure and draining CSF actually depend on us doing a wide decompression at the injury site. So if you have a situation like this, and you say you have an injury in your cervical spinal cord, if that injury swells and fills that sac, well then if you put a pressure probe there as Maris Papadopoulos has done, or put it there in the lumbar cistern, these pressures are not going to be the same, okay? And quite likely the intrathecal pressure below is going to be quite a bit lower. And they've actually shown this by actually putting in those probes into one at the neck, one in the lower spine in a small set of patients. They found that in some patients, yeah, these pressures are very different. And other patients, the pressures are very similar. And we think that this has everything to do with surgical decompression. Because really what you want is that situation where there's an intact column of water through the entire intrathecal space. And that's when you're lying flat, those pressures will actually mean something in the lumbar spine. So we want patent subarachnoid space at the injury site, not occluded subarachnoid space. And again, how do you get the patent subarachnoid space? That's when you do that's the technical part of getting a complete decompression. What we've learned is that looking at the waveform in the lumbar spine actually helps us tell if the space is open. So if that space is open, then we see a very pulsatile waveform in the lumbar spine. And if it's closed, we see a flat line. Now, this is the money shot about that shocked us, but no, surprised us about CASPER. Let's say you pull out a bunch of CSF out of somebody, you would think that the change in the intrathecal pressure would be down, right? Like let's say you pull off 20 cc's of CSF, you would expect that the CSF pressure in the sac would come down. That's kind of what the whole point is. So you would expect that as you draw off more, like 20, 30, 40 cc's, that the amount that it would change would be higher. And that's kind of the relationship we'd look at. So here's what the data looks like. So it does actually kind of go down, but the relationship is not as straightforward as one would expect, such that these two patients, for example, had 30 cc's of CSF drained in the 1 hour. And when we turn the drain off to check the pressure, this guy's pressure was 10 millimeters of mercury higher. And this patient's was about 10 lower, 6 lower. So that is something that is a bit unusual. And we're not totally sure exactly why that is. We have some theories about it, but what it tells us is it's not a totally straightforward thing to drain people's CSF to modulate their spinal cord perfusion pressure. And ultimately what this brings us to is the question of, is it really even the right metric? And the issue that I think we struggle with is, like, let's say this is your patient and they're in the ICU. And we know that the spinal cord is kind of hypoperfused around the injury site. So here they are, their map is at 75 and they're humming along. And at this moment in time, you say, we should get that pressure up. So we give them some norepinephrine and we bring their map up to 85. Okay, so now we've done that. The problem is that in doing so, we actually don't know what we've done to the cord, right? Like we don't actually know what that has achieved in the cord. We don't know if we've increased the oxygenation delivery to the cord, whether we decreased it, whether it's unchanged. And if you really can't measure it, it's actually really hard to manage it. So we've turned to a technique called near-infrared spectroscopy, which is used in many ICUs and whatnot for cerebral oximetry, where you shine near-infrared light through the skull and you get a reading of the oxygenation levels within the brain. It's the concept of basically shining light on oxygenated and deoxygenated hemoglobin. These two molecules absorb light differently. It's not that different of a concept to how pulse oximetry works. So it's like, to my dad, I say, well, we're trying to build a pulse oximeter for the spinal cord. So we had this idea, because these are used in our ICU to measure oxygenation. We thought, well, it'd be cool if we could develop a sensor that we could put on the spinal cord after decompression, shine near-infrared light through the spinal cord and obtain a measure of oxygenation within the penumbra. And we did this using our pig model of spinal cord injury that we developed. And the pig model has a lot more similarities to the human than the rat. And we started by just sticking invasive probes into the cord and seeing if we could measure those changes inside the cord with something that we just placed on the dura, which is the near-infrared spectroscopy probe. This is our first experiment we ever did in the lab, where we made the animal hypoxic and it creates a rise in the deoxygenated hemoglobin and a fall in the oxygenated hemoglobin. That's the typical sort of pattern. But I just thought it was really interesting. I was looking at it and thinking, wow, you can see the pulsations in the cord just by putting this sensor on the dura. So with the help of the DoD, your DoD, we've been on this extensive device development process, and with the goal of developing a sensor that I could put on after the time of decompression that would then be externalized like a hemovac drain. So at the end of the 7 days, you could just pull it out. So this is kind of what it looks like. And it's got these soft silicone flaps. This is actually a bit of an earlier version. And the thought was that we would put it on the spinal cord and then to seal around it, to kind of seal it down onto the spinal cord. Not glue it down, but just sort of secure it and still allow you to pull it out at the end. When we did this in our pigs, we see that there is actually a significant drop in the oxygenation around the injury site. And this is one of those things where, we took something that was a problem in patients, we went back to the bench. Now we're hopefully going from bench back to bedside with a clinical trial in this sensor. So again, with the Department of Defense, we've developed this clinical study. This is actually this is our first patient that we've implanted. You can kind of see the NIRS probe right here with a whole bunch of fibrin glue around it. So that's one of the things that we're kind of moving towards doing, and we'll hopefully enroll some more patients into that next year. Okay, so in summary, for surgical decompression, I think people still argue about this a little bit, but really it seems that the prevailing evidence is that the earlier you do it, the better. And I think we should probably consider being quite aggressive surgically in how we do that decompression, with really the notion of trying to get that CSF space around the cord. So we actually do a lot of intraoperative ultrasound to make sure that the spinal cord looks free after we've done our decompressions. And we are doing post-operative MRIs to check on that afterwards. For hemodynamic management, it's one of the, I think it's important. It is one of the few things that we can do. So if people want to see the guidelines, they've been published, they're open access. They came out in March of this year. We do believe that spinal cord perfusion pressure may be a more relevant target than MAP. And the neurosurgeons, when we published this, it's like, it's totally intuitive. It's just like cerebral perfusion pressure. So, so we're interested in exploring that. But I think at the end of the day, the spinal cord will continue to remain a black box until we have a way of measuring what is actually happening to the tissue at the site. So we're anxious to develop that near sensor for that reason. So a lot of people to thank, in the performance of all that research. We have like a great team, both in the lab and on the clinical side. Very thankful for our funding agencies. Much of that was funded by the U.S. Department of Defense, and some of the work also by DARPA. So very grateful for a lot of the support that made that happen. Okay, thank you very much. Yes.
Thanks, Bob. Good question. So I want to go back to the break on camera.
Yeah.
We all know that acid, the THC has been big. Look at the brain nature.
Yeah.
Mortality.
Yeah.
You think there's any utility for that?
It certainly is possible, and I know people are interested in exploring that just because it's another commonly used thing. And I think, yeah, I'd heard of the brain there. I think was a fairly recent brain injury study where it looks like it does actually reduce hemorrhage in the brain. So I think it's certainly possible. Now we've actually now enrolled a few more people in this, and it does look like the timing at which you start the anticoagulation is also a factor in the hemorrhage. So the earlier you start it, the more people will bleed, which kind of makes sense because it's probably earlier the microvasculature is a bit more friable, a little bit more at risk. And so the combination of driving them up and anticoagulating them is probably going to contribute to bleeding. But yes, TXA is actually something we're kind of interested in, and I know other people are as well. Yes.
Thanks so much, Dr. Kwon. Great talk. Having spent some time with that therapy, the wide decompression.
Yeah.
Question is, so obviously we saw a lot of high energy injuries at Maryland and Sean, and transitioning here into practice, still the busy trauma center, but different demographic. A lot of the cord injuries that we've seen I've treated have been people with ankle spines, devastating cord injuries, right? And I think with age demographic, with metabolic syndrome, we're seeing more of it.
Yeah.
And the patients have very high morbidity, mortality post-op. So the question for you is there a role for damage control spine in those patients where we're just stabilized rather than when they're institution doing a wide decompression? Do you treat them any differently? Do you think the sort of pathophysiology is any different in saying that somebody comes in with a motivated practice?
Yeah, I mean it's a great question, and we struggle, with the elderly individuals oftentimes when they have angst-spawn. I think we published a paper that like the mortality if they're over 75 is like 80% of them don't get to be independent. They die or they're not independent. I think in general we try for angst-spawns and dish, we do try to decompress them when we can, because if we're going to subject them to an operation, we feel like we should probably try to give them also the best chance of recovery. Sometimes their cord injury is actually a very low energy injury, right? Because they didn't injure themselves when they fell. They injured themselves because their fracture was missed, and then they displace over time, and then they come in quadriplegic. So we do in those situations try to decompress them if we can. But it is tough, I mean, the real question for many of them is whether they should have an operation at all. Right? It is kind of like hip fracture mentality in a sense, but the mortality is super high from that. But we do try to, when we can, we do try to decompress them. My mentor Marcel Dvorak, because we'd often be at rounds and we'd be like, oh well, we weren't really sure if they were, we thought maybe they were a bit too sick to have like, that operation. And he would say, well, if your patient is too sick to have the right operation, then they're definitely too sick to have the wrong operation. And but it is, I think, still those are tough patients to manage.
Can I piggyback on that?
Mhm.
So if we're thinking wide decompression, do you need the anterior portion to a posterior?
This is a good question. Yeah. Yeah.
You do anterior and then posterior. I assume maybe anterior and then some timing or repeat MRs. So how do you make that decision tree out with?
Yeah. Well, we've actually been moving towards doing like all posterior surgeries for even if you got like a burst fracture at C6. But now that we've been doing our CASM study where we're actually MRIing some of those patients so some of our CASPER patients, we actually put in our CASM study and we actually did 4 MRIs on them. And what was interesting to me was that in patients that have burst fractures, where there's a bit of retropulsion into the canal, oftentimes that bit of retropulsion blocks the subarachnoid space, even though you've done a 4-level, 5-level laminectomy. And I was the one that was kind of petitioning for that. So I think that if you really want to get it, if it's really in your mind, like, okay, I'm trying to get this thing completely decompressed, then they actually probably do need it front and back.
Yeah, there's a real subtle thing there within the fracture dislocation and realignment indirect versus a burst and some kyphosis and anterior column still compression.
Yeah. That posterior inferior corner of the broken body ends up always a bit back into the canal. And on some of these ones where we've done post-operative MRIs, I'm like, oh man, I wish we would have done something about that. Yeah. Right. But we think that we do intraoperative ultrasound to make sure that the cord is floating at the
Can
time.
you comment on that? We don't really do that.
Oh, you know what? It's a beautiful thing.
Yeah.
As an orthopedic surgeon, like I never used to use ultrasound.
Yeah.
I use it all the time now.
Yeah, so how
Yeah,
does that
So
work?
basically, we do the decompression and you bring in the ultrasound. It's a little hockey stick probe. There are a lot of different little probes, but then you can just look at the cord both axially and sagittally, and you can just see it floating with the pulsations of the heart. And that's always a very reassuring thing.
No specific prognosis sequence of ultrasound. What do we
Yeah.
ask for?
Yeah, no, like they turn it on and usually you can just, the nurses can fiddle with the depth a little bit, but it's pretty easy. And that's what I tell people when we ran a course at AO Spine last year about it. It's like, and then I was there with all these neurosurgeons and said, look, I'm an orthopedic surgeon. I find it really easy to use and it's a wonderful tool for, not just for coordinators, but like cervical myelopathy. And tumor decompressions, like particularly if you're like interested in only addressing the posterior part and leaving the ventral pathology and expecting that the cord is going to float away from it. It's a beautiful way to confirm that you actually have achieved that. Yeah, yes.
Well, that's the non-spine.
Yeah.
Fascinating thought. It seems like one of the things that is difficult in our world of trauma is trying to assess how much injury is actually there. And it sounds like some of the things that you're talking about have to do with how much injury is the cord that we're using fairly inexact tools. Like displacement there is.
Yeah.
You know, how much, what's their age status, which clearly fluctuates and can improve, so it was interesting when you talk about the measuring interparenchymal hemorrhage. That would be sort of a marker of injury.
Yeah.
Sometimes we're looking at studies that look at how much components in the abdomen as sort of marker of injury, but because it seems like also some of these patients are going to be fairly heavily injured besides their spine.
Right.
So one of the challenges to operating on someone within 8 hours might be not that you don't have operating time or you can't get to the operating, but their spleen is in.
Sure, yeah.
That is, how other injuries that might sort of limit how much surgery they'll tolerate.
Right.
And so I guess the other question is, talk about steroids, kind of how maybe managing the development of the injury, the inflammation, and the injury. You talked about regulation, but wondering if anti-inflammatory type processes might be helpful in that subsequent period of time to manage how much injury affects the surrounding cord.
Yeah.
Because I think we have trouble knowing how much injury is there.
Yeah.
And then, so then the question might be, who might benefit? Maybe there is a subset of patients who might benefit from steroids or other anti-inflammatory type medications to try and limit the inflammatory response to damage the surrounding tissue.
Yeah. Yeah, I mean, I started my career really interested in post-traumatic neuroinflammation, and that's what we did in our CSF sampling. Was we actually we're putting these lumbar catheters and we're getting CSF samples and actually looking at that to look at inflammation, see what, but interestingly, we've kind of come full circle now. Our biomarker work is actually focused on blood. So, and for this exact, for one, it's obviously easier to get, but the idea of using the blood as an objective marker of how severe the damage is to the spinal cord. So we have 2 markers, GFAP and neurofilament light. We're actually in the midst of a validation study for that.
Taking blood samples or sampling
peripheral blood, yeah. Well, because in our trial, we actually had, so every time our nurses take a CSF sample, they also take a blood sample. So we actually had about 120 paired CSF and blood samples to measure BFAP and neurofilament light. Now, and it turns out that it's like 1,000 times higher in CSF than in blood, but there's actually still a very strong signal in blood. So we're pursuing that now. We're doing a validation study. We're going to actually do an international study through AO Spine of sites that are going to draw blood samples and send them to us in Vancouver. So, because defining the injury in a way that is like less dependent on the in-ski examination. And for all the residents that see acute spinal cord injury, it's like the worst experience ever, because you're down there in emerge with this like traumatized patient. They have maybe multiple injuries, and like you're doing a rectal exam and asking them like to squeeze down. Like that's like the pinnacle part of the exam. Like it's a very, it's a very challenging thing to do acutely. And the rehab docs are, we try to explain to them, no, like this exam is kind of unreliable. They're like, oh no, but they don't see people in the trauma bay, right? The trauma bay is a very different, scenario to do this kind of exam. And plus you don't have an hour, right? Like you have to like do the exam and like move on. So if we had a blood test that would tell us, okay, this is what the patient's like, then that would actually, I think, really facilitate decision-making early. Josh.
We have responsibilities. Maybe we stick with questions and stick the second part.
Yeah, whatever you'd like, yeah.
Yeah, so I think spinal cord injury still need to do a surgery, the compression. When you do the anterior and the posterior, do you stage it or during the same day?
No.
Levels do you do the compression? Level above, level below?
Yeah, so I don't stage it because I figure if you're going to do it, you might as well do it at the time that you're there, because that's kind of probably the earliest that you're ever going to be able to do it. And then I try to look at like how sometimes people are actually stenotic, right? Especially like in older patients, they might have had their injury at C5, 6, but then they're kind of stenotic all the way up to like C3. And so I'll actually look at their scan and decide, okay, well, where would I have to go to in order to get CSF around the spinal cord? And oftentimes that means going up to C2, down to like T1. But I do try to look at their native like morphology. And I do think here there are a couple of technical issues. One, this is where I've argued with Bijan a few times, because it's a Bijan, like you can't tell everybody to do a 5-level laminectomy on everybody. Like that's crazy. But clearly you see people, some people have a very capacious canal, right? And so I look for that. If I look and I see that, somebody has a very capacious canal and a torque ratio of, where they've actually got, almost as much CSF space around their cord as their cord, then those patients actually might be fine with an anterior procedure alone. Like because even if their spinal cord swelled twice to what its normal circumference is, they would probably be fine. So I do look at that. I look at the native morphometry, but then I also think it's super important to have after you do the laminectomy, whether you do 3 levels or 4 levels, or whatever, super important to actually realign the spine and make it lordotic. Because by making it lordotic, then you shorten the posterior column and the fecal sac has a chance to billow out outside of the laminectomy space. And you always think of that like when you do cervical laminectomies for myelopathy, and you always feel like, it seems a little tight at the bottom and seems a little tight at the top because the fecal sac has expanded, it's billowed out. And that's actually what you want to try to achieve. You actually do want it. You do want it to, you do actually want that fecal sac to billow out, so that creates the space around the spinal cord. And I've seen a lot of, now that we're kind of looking at this, it's interesting how if you don't pay attention to the alignment, that you can definitely get situations where you don't actually get that expansion of the fecal sac, and when the spinal cord swells, it fills it. I think that
So that was that going back to your statement, is it canal space or is it pressure perfusion? Obviously, you said as well.
Well, probably the pressure perfusion has something to do with, well, with how well it's being decompressed. So, and I think that this is also one of those things that Papadopoulos has kind of shown. Oh, shoot. Okay, so you notice that there's the edge of the lamina there, right? And then the fecal sac expands into the laminectomy defect. Right? And I think that it's important for that. But if you imagine this spinal cervical spine being kyphotic or straight, then you don't get this expansion into the posterior. You need to actually like take them out of the Mayfield, extend them, lock them in that position, and then and that's actually what creates this ability for the dura to kind of expand into the laminectomy space, and that gives you that. I don't know, is that what Bijan would talk about? Yeah, because it's interesting because and even in some of Bijan's papers, you look at some of those papers at the ones where they didn't have a fully patent subarachnoid space. Many of them are kyphotic, where they're straight, and so in looking at it, you know, you can kind of see how alignment. So it's funny, and this is actually one of the reasons why I kind of think like patients with cord injuries, they're just better served at centers like this and not out in the community, because like these are the things where like if you're out in the community, you do some cervical myelopathy surgery, then you're not necessarily going to be thinking of all these issues when you're decompressing these patients.
The patients that you're doing the multiple MRI studies on,
Mhm.
have there been anywhere on the second or third MRI, you said, yeah, we're actually heightened somewhere. We thought we'd decompress this completely, but now.
For sure.
So has anyone actually gone back to the?
Yeah. Yeah. Yeah, particularly at the upper or the lower levels. Yeah. That's actually one of the good reasons for the ultrasound is that you can intraoperatively sometimes say, ooh, I think we should maybe do a little bit more at the top. Usually it's, well, there intraoperatively, it's a decision about doing more at the back. Yeah.
You use the ultrasound probe to posterior.
Yeah.
Your posterior laminectomy and trying to see it.
Exactly. Yeah. Yeah. There is a probe. One of my neurosurgical colleagues used it because she's used it for cranial stuff that you can actually use for the front but I don't know how great that is. I usually use it from the back.
You need to have exposed dura.
Yep.
So then by definition, wouldn't that be decompressed? You want to check the upper and lower edges, which is ventral to the bone, which your ultrasound as far as we can't ultrasound through that, through the change of the.
Yeah, but you can tilt your probe and actually get a look at like just where that last bit. You usually go in the sagittals. Yeah, you can kind of catch a little bit under the lamina.
Is your probe that you're making MRI compatible right on the spinal cord? Will they not get an MRI once you put your?
Oh yeah, yeah. Well, one of our things that we did with DARPA was to actually try to make it MRI compatible, but and they're doing testing to see how much it moves within a magnet. I'm kind of the opinion that like if the patient truly needs an MRI, we might just take it out. Yeah, just because we don't. For one, it's probably if it might not necessarily be a problem, but it might obscure it a bit. So, yeah.
I should have, Dr. Kwon, I have a question,
Mhm.
as chair, in terms of how you've gotten buy-in from your institution. Because, you know, with COVID and staffing shortages and access to OR, then always a excuse that you don't have staff, anesthesia, that can't do the case, doesn't want to do the case until later, and you bump it to the next day. There's a lot of variability in terms of us getting some of these cases to the OR. I think we're good with the acute injuries, but just in general, how have you built this team? And what would you say was your success? Because a lot of places, I mean, we're a level 1 trauma center. We're the largest spine trauma center in the state of Virginia.
Yeah, sure.
And we have a hard time keeping staff because doing spine cases in the middle of the night is challenging on staff.
Sure. Yeah.
it's really tough, so.
Yeah. Yeah, I mean, I think that we've been lucky in that we've been the spinal cord injury center for like our province for a long time, and that people, I think, institutionally know that when these cases come in, they take on a higher level of urgency. Certainly, I do a lot of work socializing stuff because these cases touch upon radiology and emerge and ICU, and so establishing like relationships in those areas so that people know, okay, yeah, like we understand this has to be done quickly. When we created the pre-printed orders for hemodynamic management, like I had to do rounds in ICU and grand rounds with emerge docs, just so everybody was aware. And it is interesting how that changes culture. Like I would get to emerge and people would be like, oh yeah, where are the pre-printed orders for the hemodynamics? And it just became part of that. But I think that so somebody, I mean, like anything, somebody needs to champion it. And then look at, who are all the people that touch spinal cord injury patients. And it often ends up being like a lot of different departments within the hospital. But yeah, I mean, we're very lucky that there's a lot of like-minded people that want to, and I think everybody just naturally wants to do something because it's such a catastrophic injury, and they want to do things that might actually help the patient in this case.
How much your patients get into or in 8 hours, 24, like what's your stall?
Yeah, I mean, I guess our problem is like we have a big province, so like sometimes our patients don't arrive to us like between like until they're 18 hours out. I would say that, from the time that a patient hits the door to us being able to get them in the OR can be 3 to 4 hours. So usually if we know ahead of time, then we're actually like booking their MRI and booking their OR, and then the OR holds a room for us and we bring them straight from the MRI. So
Everybody gets an MRI.
usually, yeah, there's a few situations where people might not. Like I think if somebody has like a badly displaced T9 fracture dislocation, they might get taken to the OR right away with that. Yeah. Yeah. So. You mean in terms of improving outcome? Yeah. 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 Well, I mean, I do think that like the system of care, getting people to the operating room quickly, and then making sure that there's alignment between the surgeons and the intensivists about hemodynamic management. I think that's, I think that's important. We have a fairly well-aligned rehab department, although in Canada, like they often don't take rehab patients. They don't take our patients for like 6 weeks. So it's unlike, we're managing them for like 4 or 6 weeks, and then they go to rehab after that. There's clearly importance to that, having that continuity of care and that spectrum of care being delivered by people that actually understand spinal cord injury. We know that there are some spinal cord injury patients that get stuck at other hospitals because sometimes after a while they get sent in. And it's just even simple things like, we had a patient transferred from another hospital and they didn't have like the call bells that you could use unless your hands were working. And so, you get a central cord injured patient. Yeah, they get put on some ward, and then like they're screaming for the nurses because they can't use their call bell. Like things like that, that's clearly not good for patients. So having a system that I think accommodates that.
Another question. Some of the issues you talked about with math, something it's very subtle, right? You're talking about some sort of fine details. How do you translate that into a system-wide thing? Because you might say, oh, I know this group of patients really like math, but maybe a little bit lower, maybe a little bit higher. That doesn't really translate into ICU report instead of
right.
doing 24 hours later.
Yeah.
But I think some some of the challenges in these environments are translating some of the things that you want to do into a more of a system proof
Yeah,
thing, so that you say, look, there's no way we're going to keep this map between 72 and 74, but we're going to have this range. But, I guess that some of the challenges sometimes is when you identify subtle changes, like, hey, cervical spine, maybe we want to do a little bit different, or lumbar, this patient, because they have a little different shape forward, we're going to do things differently. That sometimes is difficult to translate in a large system. Like
absolutely.
here.
Yeah.
That's some of the frustrations we've seen.
Yeah. Like it was funny when the ICU guys were after me about this. They're like about this paper, these guidelines. I had no idea that they would be reading the Global Spine Journal. But yeah, it's very important, like to actually go to their rounds. I gave them like this whole spiel just on hemodynamics, and now they're they want to know, what would you like to do? I think the real subtleties they'll come at the bedside, and we found this to be a struggle because an ICU is housed by like 300 different nurses. They all have kind of their ways, and to try to get them to change, and they're the ones that haven't had to really deploy it, right? So we found that to be problematic, particularly for our CSF drainage protocol, where in some ICUs they're like, yeah, we always just drain 10 cc's an hour. That's kind of been the way we've done it for years. What we've discovered is that does nothing to their intrathecal pressure. Like 10 cc's an hour does nothing. So you need to really kind of ramp that up. But because that part of the care is deployed by the last person at the bedside, which is often the nurse, and there's 300 of them in a unit, and they're not all going to be the same ones doing your study, that part is challenging for sure.
Dr. Kwon, that was a fantastic journey through your, long career in developing clinical protocols and that are used internationally, as well as developing an incredible spine service. Just a few tokens of appreciation, including some UVA Ortho swag in this bag.
Cool.
And then, of course, the Donald
Wonderful.
Chan
Well, thank
Visiting
you for
Professor
that.
in Orthopedic Surgery. So just a few gifts for you here. So but thank you very much.
Thank you for the
visiting. I wish
invitation,
you
yes.
could stay so we could
Yeah.
show you Charlottesville
Yeah.
and show you UVA.
Appreciate it. Yeah. Well, certainly appreciate the invitation, and no, it was a real pleasure to be able to come.
It was just remarkable what you've done. So.
Thank you. And you're going to catch up with Adam too.
Yeah, I will catch up with Adam in Chicago.
All right, guys.
Yeah.
Thank you, everybody.
Thanks, everyone.
Maybe we should get some of the back with you.
It's hard to build these, to get buy-in. I mean, I've struggled so hard for decades, trying to get more consensus. I'm a hand upper extremity, and just for me to get, and there's only 2 micro centers in the state of Virginia, and we're 9 million population. So trying to get a micro team for middle of the night cases and replants has been, I mean, it's the same struggle I've had for spine.
Sure.
Because everyone wants to push everything in the morning.
Right.
And and I'm like, we can't wait till the morning.
Yeah.
There's 3 fingers off and a 6-year-old, right?
Yeah.
So we got to do it now.
Yeah.
So it's been a real challenge.
Yeah.
Like you said, it's building consensus and having that physician champion who goes around and talks with everyone, and does the grand rounds and talks to the nurses, and it's everything you've done. It's evidence-based.